next to Representative Ottman, so
Yeah, he's over at his desk. You want me to run over and help him get on?
that would be super. Thank you.
Yes, he said he's ready. He can't get the sign in for the webinar.
You know, all I ever do is I go to the calendar, the little calendar picture on the bottom left of my email screen, and click on that. I mean, of course, you have to have accepted the invitation previously, but I actually only accepted my invitation this morning, like about 2 minutes before I went to the calendar page, and then just click on the calendar page. That's all I ever do. I don't even find that I need to. People have been articulating some problem with like finding passwords. I know on like breakout sessions or rules committee, and I'm like, nobody ever asked me for a password. I don't know.
Chairman Wilson, we are live.
Okay. Good morning, world. If I could do accents, I would pretend that I was the BBC or something like that, but I'm not good at accents, actually. So welcome, Wyoming. This is the House Labor, Health, and Social Services Committee, and we are here to consider Senate File 54, Statewide Health Information Exchange Codification. And we have a few rectangles vacant, but some of them I know they're actually here, but I guess we'll proceed. Carla, we'll go ahead and proceed with the roll anyway.
Thank you, Madam Chairman. Representative Clifford.
Here.
Representative Conley.
Here.
Representative Flitner.
Here.
Representative Hallinan.
Excused.
Representative Ottman.
Here.
Representative Romero Martinez.
He's excused because I know he's actually here.
Representative Stivar.
And he's excused because he's helping Representative Romero Martinez.
Representative Wharf.
Here.
And Chairman Wilson.
Here.
Thank you.
Thank you. It actually seems kind of funny to have a small group after all the interim of so many more people on the pages. You know, I feel like, and of course we've been Zooming all through the day, like with 60 people, and I only kind of condensed everybody down to about 10 people so I could have all the other pieces of paper. To actually have everybody that we're trying to talk to right here on one screen is really kind of a novelty. So this, where'd Carla go? Oh, there you are. Or she's back to her picture. We'll let in, I assume Jesse Springer will present, but I'll just give a little, while you're working on that, if he's ready, I will just give a little overview. Okay, so committee, this was a committee bill, as you can see. And the reason it says Senate Labor is because what we do at the end of the interim, we had 7 bills, and then the Senate chairman and I just divvy them up, you know, half to one side, half to the other. Really no particular meaning to, you know, you just try to even out the work. Like, for example, the 2 that we did last week we had the mental health licensing one and the addictions practitioner. Those were sort of thematically related, so we put them in at the same time. So this is just another one that we worked during the interim. And hopefully the health department, because this really came from their work, but I do want to just point out a couple of things that we did in the interim so that you're aware of them. The bill, we considered it at, I think it was our October meeting. And just so you know, on page 2, that top paragraph, we had an insertion about, it might be rather puzzling if you didn't hear the discussion in the interim, but the first couple of lines of page 2 say, except that the term multi-payer in that section shall not be codified, kind of blah, 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 to the end of the sentence. And I realize you haven't really heard the explanation of the bill yet, but I hope you had a chance to read it over. This has to do with basically a medical record, kind of a exchange system. So it's not really a state function, but the money came through the state to basically do something where suppose you have had an X-ray in Riverton, and then you get transferred to Wyoming Medical Center, and then they can access your X-ray film without you having to do the old-fashioned thing of carry along a giant envelope of film. I mean, that's really all that's happening here. But it was originally started up in the 20 2017 or 2016 session law in a footnote, like there's a budget footnote, and there was a phrase to multi-payer in the footnote. And what we discovered in the interim was just that there had been, frankly, some confusion in drafting up the footnote because we were doing something with multiple payers, different insurance companies, and it had absolutely nothing to do with this topic, actually. So Senator Scott just said, well, let's just clarify that multi-payer has nothing to do with anything. And so that's what that sentence is in there for. Then in paragraph B, we made the change on line 12. So you see the real goal of this is to enable the department to charge participation fees to cover any cost. When the whole process was stood up, there was a lot of federal money with like a 10% kind of a copay, so to speak, from us. And now we're going to have the fees too. But we wanted to be clear that the participating entities are like the hospitals and clinics, that patients shouldn't have to pay to have their information go in this. And so that was another insertion that we did during the interim, line 12, not including individual patients.
Madam Chair,
Representative Connolly.
may I ask a question here?
Sure.
I'm curious, what is a participating entity and is it defined anywhere in statute?
I think when Jesse Springer from Department of Health, because I'm not really giving an explanation now, I'm just pointing out the changes. You will hear who all the participating entities are. And the other thing that I just forgot to mention, on line 6, we just wanted to clarify, and this is existing practice. So this record system has been up and running for several years. On line 6, you note it says secure and voluntary. It had previously just said facilitate the secure sharing. And we just wanted to make sure that it was understood what is current practice, which is that it is voluntary. Nobody has to participate. In other words, if we're going to charge a fee of whatever, a couple $100 or something to a hospital for participating, that's voluntary. They don't have to if they don't want to. So those are just, while we're waiting on Department of Health, I just wanted you to see what the changes had been from during our interim. And other than that, it's I thought a fairly short one to start us off with on our committee work from the Senate files. So Carla, do we have Jesse?
No, we don't have anybody in the, excuse me. No, that we don't have anybody in the waiting room just yet. I just resent confirmation emails to each of them and a separate email to Mr. Spring.
Oh, well, then maybe I will, I kind of hesitate to present and botch it up, but I will try to do that because in our committee, I kind of apologize for this, and I'll apologize to them. Normally what I do when I'm scheduling bills is I email the agencies who are relevant and say, hey, does Wednesday 4 o'clock work for you? Or what, to make sure they've not got some other thing going on, because they do have actual regular work. But I kind of spaced that on Friday, just the new session and the Zoom and everything. I didn't really do that right. So normally because this was something that they brought, they would be here. So I apologize for me, and they don't really need to apologize because it's not really a fault. But so here's what we're going to do, committee, because I just want us to not drag in. Obviously, we need to finish before the chamber work starts. I have my printout, and I did send, when I sent you out an email Friday, I said I'll find the handout, and I could find out my printed version, but I couldn't find where I had received it. So you don't even have that, which is good because that way I don't have to attempt to share screens, which I haven't done yet before. But I will just basically summarize what this is. So, and you'll apologize. I hope you will forgive me. I'm kind of reading off because that's the best way to say it. So the state health information exchange is basically, if you think of it, if you're taking the bus or the train or something, and you can come in from such and such a line, and then at a hub you change trains and you go out on a different colored, the red line or something like that. That's kind of like what this is for medical records. The clinic can put in let's say your X-ray film, and then the hospital can take it out. So it's kind of the hub part where it does the in one record way, out the other record way. And as you probably know, not everybody's got the same kind of medical record software. And so you have to have sort of a hub. Representative Connolly.
I'm so sorry, Madam Chair. I have a message from Representative Hallinan. He needs some help logging in, so I'm wondering if some LSO staff could maybe reach out to him.
Carla, could you help him?
Sorry for the interruption.
No, that's good.
And yes, I will, certainly, Chairman Wilson. And I see that I have a couple of other people that aren't seeing us up on YouTube, but I show that we are on YouTube. And so it looks like there are some issues with it this morning. So let me step up and see what I can do to help.
That's right. You do what you can and we'll just carry on. You know, the legislature functioned before the beginning of the internet, so we'll just manage. Okay, so this system, and they call it for short Wi-Fi, Wyoming Frontier Information, whatever. And it says, allow the provider electronic health records to securely share prescriptions, lab results, radiology reports, discharge summaries, allergies, consultation notes, and transcribed documents. Helps doctors, hospitals, and providers to improve patient care. All 50 states have at least one health information exchange. And I'm just going to skip ahead and come back on this, that the connection to the Colorado exchange is in place. And of course, down here in the corner of the southeast corner of the state, you can imagine that a lot of patients go down for referrals to Colorado. The Utah one was supposed to have come up in October. We can confirm that with Department of Health when they come on. And the South Dakota one was also supposed to come up in October. And the Montana network was going to go live in the week when they presented, which was, I guess, also October. So, you know, you can see that for the most part, the surrounding states, people who go out of state from Wyoming to these other states will be able to not be stopped by, you know, the border of the state. So as you obviously know, I mean, most all of us have had the, I don't want to say misfortune of being a patient somewhere, and you know that to have information on what, you know, your accident or your allergy or blood type or that sort of thing, obviously improves your care. You know, we all know that sometimes the doctors don't always read everything and they ask you anyway, but we like to think that that's just to confirm what they're doing, right? So obviously this supports telehealth. It does, the idea is obviously to be more efficient and not be shuffling paperwork all around the time and delays. You know, you can imagine if you were transferred to a hospital, you hate to wait until you can manually get, and I started working in healthcare back when everything was on paper. So, you know, but to transfer everything, to get, you know, permissions and send this in there. And of course, this all complies with HIPAA, the infamous HIPAA, which we all know and love so much. And the idea being to reduce redundant testing. Yep.
Excuse me, Chairman Wilson. We have 4 people in the waiting room right now. So
Good.
I'll
Who do
bring
we have?
up. We have Renee Blair, Eric Boley, Jesse Springer, and Ryan Jackson.
Okay, let's bring up. Let's do them a little bit at a time, just so we don't have if you bring in Jesse.
Okay.
And then we'll have Aaron and Ryan after that. And then if we have time, we can bring in Renee, but she has sent us a good email, so we can. Let me just see here. So Jesse will probably kind of confirm some of these things. Oh, there we are, Jesse. Look, I was trying to do you. So I had on paper, oh, it's not, it just looks like a big white blank. There it is. I'm working off of the paper presentation from October or whenever it was. So Jesse, you can, thank you. And I really apologize, Jesse, for failing to email you guys on Friday and say, hey, how about 8 o'clock Monday? I do apologize because normally I do that. I'm not used to my crack of dawn Monday morning meeting thought just yet. So what I filled them in on, Jesse, was, you know, that PowerPoint that you had about that is called Wi-Fi, the various things that you can share through there. And I talked through what in October, anyway, the anticipation was as far as surrounding states. So Jesse, if you're set, if you want to kind of pick up, well, wherever you feel comfortable with, maybe the legislative history, the implementation status, who the participating providers are, and what the purpose of the bill is, that I guess will probably be good.
Chairman Wilson, thank you very much. This originates out of, this program was funded as a budget footnote a few years back. And so we've been busy implementing the program. But the legislative authorization was quite limited. So it gave us funding and directed us to build a system. And then we've been proceeding off that budget footnote and promulgating rules and trying to build a structure for this to operate. There's certain things that we could not do without legislation, which are to collect fees from the participating members, which we see as being crucial in the long run for sustainability of this over the long term. And this is a program where the medical providers, especially the hospitals, appear to be willing to contribute because it does benefit them and their provider networks to coordinate information more easily. So the main purpose of the bill is to create the program in statute, and then to create a mechanism that the program could collect fees from users only, voluntary, because all participation is voluntary, and then to retain those fees for the direct use of the program, so that the thought is they'll be much more willing to contribute if they know the funds are set aside for this specific purpose.
And Jesse, do we have a thought? I'm not sure that we knew at the time that we first heard the bill. Give us an estimate of what the fee level would be, say for a large hospital, a clinic, that kind of thing.
Chairman Wilson, I think by the time we're done building this, we'll have about 3,000 users. So the fee structure could be somewhere between $10 to $20 per user per year. So quite low. I mean, so this is generally medical professionals. So this would be a supplement to something they would be paying on their electronic health record. And so for a large hospital, it could be in the tens of thousands of dollars for something like Cheyenne Regional Medical Center. But for a small practice, it could be, maybe less than $100. And certain providers that are participating will probably need to work through whether they can pay fees or not. So there's different uses like the emergency medical services providers, and some of those services don't collect fees currently, or they have very limited fee collection, so they may not have money to participate. So we may need to work through if a provider does not collect fees or does not have any revenue, that they don't have a fee, because we wouldn't want to discourage participation from those essential providers.
Okay, Jesse, did I interrupt you in the middle of a planned presentation, or do you want me to? The committee, there's 6 of the 9 members of the committee are new. So that's why I said I gave kind of an overview, but do you have that PowerPoint that you had back in the fall at all, or shall I just ask questions?
I can get to it pretty quickly. I wasn't planning to do the PowerPoint today, Chairman Wilson.
How about if I just ask questions off of my PowerPoint to kind of have an imaginary PowerPoint that people can visualize in their own heads? So the list of participating providers. So when you say around 3,000 users in the future, you pretty much have all or most of the hospitals in the state, and then the rest is various clinics, doctors' offices, that sort of thing. Is that right?
Chairman Wilson, at this time we have 9 hospitals and their medical systems. So, for example, somewhere like Campbell County, their hospital and a very large number of their medical providers are actually part of one network. So when they joined, a good portion of that community actually is participating now. So overall, as of December 2020, we have 1,500 medical providers. So we're quite, we're, I think, pretty good on the progress that we've been trying to make. Our goal for the end of 2020 was 1,000 providers, but we've actually seen much more need for this and much more demand during the pandemic, as a lot of offices kind of went to remote and low working, and so they really needed, they've really sought this out, and participation has really been growing quite quickly.
Okay, so the list that I have from the, I think it was October. Now you said 9 hospitals, but there were 9 on there then. CRM, Cheyenne Regional, Cody, Star Valley, Platte County, Torrington, Washakie, Weston County, Memorial of Converse County, and Crook County. But then it said, which is 9, but then it said Campbell County to be live by October and Wyoming Medical Center soon. So have those 2 organizations joined yet?
Campbell County has gone live. And then Wyoming Medical Center, we're completing some additional reviews that they've requested.
Okay.
So they've completed all the technology onboarding, but then they had some additional forums and discussions they wanted to have with us. So we're doing anything they've really requested.
Okay. So then in committee toward the end, then just for people's information, the information that they gave us, naturally, this all complies with HIPAA. I mean, it would not even be possible to come up with some sort of computer system nowadays that doesn't comply with the federal HIPAA requirements. The mental health and substance use notes are not allowed to be in here, and I believe that that is by policy. Is that right, Jesse?
That's Chairman Wilson, that's correct, but it's also, there's limitations on certain data that can be shared by federal law.
Okay.
So we've stacked some policy that we think people would not want this certain data shared with protections that are already under federal law. So there's a number of mental health and especially substance use protections.
Right.
So if you, we're actually not able to share anything substance use related.
I mean, which actually, from a medical perspective, is kind of a pity because that would probably be helpful, but that's as it is. Also, I see excluding genetic testing data. And so then maybe let me just state this, Jesse, and then you can circle back. You had a list of prohibited uses, marketing, research, fundraising, or health insurance underwriting. And so I believe you said that you have a sort of a policy committee of you and various providers. Can you just talk about that?
So we have an executive, Chairman West, we have an executive committee that's composed primarily of providers. And so we have hospital representation, we have the Primary Care Association, we have the Medical Society on that. And then we also just have either the privacy officer or actual providers on that committee. And they're helping to steer us to make sure we're using the data in a way that the providers would expect it to be used, because they're subject to protecting the data themselves. So they want to make sure we're not using the data in any way they would deem inappropriate, because, you know, in essence, all of this data is the provider's data. We're just the mechanism that they're sharing it with each other.
Right.
So, you know, and it's the patient's data. And so the providers under HIPAA are charged with protecting their patient's data. So they're very interested in the security of the system, making sure that it works. And so, you know, that flows into this system. And so some of those prohibited uses are by our policy that we just didn't think that people would want those things shared. And that was after discussions. We had a lot of, at the beginning of this project, a lot of large meetings with large number of providers, and they shared concerns with those types of data. And so in some cases, we're not enrolling those providers at all. So in the genetic testing example, we're just not enrolling genetic testing providers as a data sharing source. So we're not even creating the opportunity for them to have an error and share that data. So we just don't want them to join at this point. In others, we're having to suppress certain data. So we've had the providers suppress it to not send it. And we're also working on mechanisms that if it ever was incorrectly shared, we have mechanism to suppress it from being sent out.
And then the final point on that, and then I'll open it up to questions. I see Representative Ottman's got her hand up. There was also a discussion in the fall. This system, like most of the systems, is an opt-out system. In other words, every patient, when you are, you see your provider, a provider who is in this, participates in this, they're supposed to get either a form or some way that they can opt out of having any data shared. And you can also go online to the Department of Health, I believe, and opt out there as well. And it opts out through the system. But Jesse, make sure I've stated that correctly. And then I'll take Representative Ottman.
Chairman Wilson, I think you stated it really well. And when we began this project, at that time, it was quite rare for these type of systems to form themselves as opt-in. So the very early systems mostly formed as opt-in systems, and most of those failed or had significant challenges. So at this point, and I'm not sure of the number, I'm really sorry I didn't come with the PowerPoint, Chairman Wilson. I think there's about 38 that have that are opt-out states, and then about 4 or 5 that are opt-in. And the opt-in states have really been challenged to get participation because basically, like, people want this to happen, but then they don't really fill out forms. And so then you end up with like 5 to 10% participation. And then when people need it, it doesn't work. So those systems have mostly, even the ones that formed as opt-in, have been moving to opt-out. So like Vermont's a good example. I believe like 2 or 3 years ago, they actually transformed their system from opt-in to opt-out, mainly because they were having challenges of actually just operating.
Representative Ottman.
Yes, thank you, Madam Chairman. Can you hear me?
I can.
Okay. Just a point of clarification, because this is all new and I know that you've been through it again and again and again. But from the setup of this, you said it was a footnote. So it was an idea that went along with a topic. But is Mr. Springer, is he with the health department? I mean, how does all that work? Who is he with? And how is the state, then the state is going to generate revenue? Is that what I'm understanding?
That good question for clarification. Sometimes those of us who have heard it so many times forget. Yes, so
Okay,
in the budget, I think it was the budget, back in 2016, must have been just a budget, must have just been session law. In the supplemental budget, I guess it must have been. No, wait, the odd years are supplemental. So it must have been the budget bill. Excuse me, probably appropriations when they drafted the budget. What you can do when you have the whole budget, the agency budgets, you can say, okay, here's the Department of Health's budget, $1.5 billion, whatever it is, and this much money for this and this and this and this. The Appropriations Committee will occasionally just put a little footnote at the bottom of the page and say, of this money, such and such an amount of money is appropriated, to match this other amount of money, of federal money, to build out this system. And that's basically all it did. And so the whole thing from them has been running since then. And it was appropriated through Department of Health. And I don't actually remember this happening, although I was in the legislature at the time. But it would have been appropriated through Department of Health because there was a federal money that came out and said, hey, this will help everybody with their telehealth and whatnot. And so we'll give you 90% if you come up with 10%. And that's all. So that's why Department of Health got the operation of this really as a, rather than having it be run by any given provider whose job is to provide healthcare, Department of Health, as sort of a centralized agency, did it. And because that was how the federal money ran. Jesse, you probably know better than I. You were there too.
Chairman Wilson, I think going back, there was actually a private initiative, I think almost a decade ago, or maybe about 8 years ago. And that initiative actually took federal money and then ended up failing. And so when they recircled back to this, the legislature asked the Department of Health, and specifically the Division of Healthcare Financing, to host this. And so I think it was delegated to the Department of Health as a budget footnote. And then the director at the time asked the division to be the implementing entity, mainly because we have experience with many large technology projects. Let me just insert there, Jesse, just so Peppy, you've moved location on my screen. Now you're on the other side. Division of Healthcare Financing is the Medicaid office, and so they obviously are paying a lot of bills for clinics and hospitals and places, and so that was where Department of Health's technology or telehealth activities first took place, because that's where we're paying bills in dealing with records. So that's probably, just so that you know what healthcare financing means. I'm sorry, go ahead, Jesse. And Chairman Wilson, at the time we were operating this program we're talking about today is a statewide health information exchange. So it's for all state residents that have not opted out. And in that presentation, we talked through a number of processes that individuals that don't want to participate for whatever reason, and we don't really, nobody needs to justify themselves. So if they don't want to participate for any reason, they can either use the opt-out form on the Department of Health website, and we'll get them opted out, usually within the same business day, but always within 5 business days, or they can directly opt out with their provider. And so almost all electronic health records have a opt-out box that opts out from data sharing outside of that electronic health record. And so we encourage individuals to opt out with their provider directly. And if you opt out with any provider, you're opted out from all providers. So generally, if you've opted out in any of your providers, we're only able to opt in or out. It's not like a menu. And so if anybody wants to do that, we've done education. We've sent forms for opt-out to providers. There's posters that we've provided. And so, it's in that stack of forms you get when you go to your medical provider. It may not be something you are thinking of at the time, but we also have tried to create easy mechanisms for people if they choose to opt out. And we've had less than 50 people to date opt out. And we've had larger number of callers, but our staff has actually explained what the system is. And at that point, a number of people have chosen not to opt out.
Okay, more questions for Mr. Springer? Representative Ottman, is your hand is still up? Is it just, do you have another question?
Thank you, Madam Chairman. Just to follow up. So this is through the Department of Health with the tech part of it that through Medicare that's already been set up. So this was just another job or opportunity that they're providing. And then does the Department of Health have payables and receivables? Is that what I'm hearing? And I was wondering if Mr. Springer's department is actively seeking the other hospitals in the other states to participate, if that's how it works. I thank you for your patience. I'm just trying to get it all clear in my mind. Thank you.
Before he answers, let me just clarify, when you are talking about payables and receivables, I'm not sure I understand how that fits into the medical record question.
Well, what I was wondering is since there's a fiscal note and there's charges to the hospitals and stuff for that, does that come back into the Department of Health's budget, or where does that go?
No, that's a good question. And so if you, on the fiscal note, and I'll let Mr. Springer answer too, but this is one thing that you'll see when you read fiscal notes. So you'll see that it's listed to be a special revenue account. And I think, it seems to me that we may have had discussion about this on the floor about something else, but it's turning into a fog. But so in this case, it would be labeled SR in a budget. And so that the money that they collect from this would only go for the operations of this. Mr. Springer, feel free to flesh out my discussion.
Chairman Wilson, that was a good explanation. The Department of Health pays out hundreds of millions of dollars, and I'm not in charge of Department of Health, so just to be clear, I'm a mid-level person. So the Department of Health pays out Medicaid payments for services provider, mental health, public health, all sorts of things. So there's payables going out all the time. And so most of those, almost all that money goes to Wyoming communities and for direct services provided. In this case, we're providing the service and the medical community is willing to pay. And so that's why we've requested this be set up with a special revenue account so that it'll be distinct and separate from our general revenues, which are swept every 2 years. So at the end of our biennium, any appropriation that's unspent is swept back into the various funds and either legislative reserve account or permanent mental trust fund, however the legislature chooses to do that. In this case, if we had donations and contributions during that 2-year period and we hadn't spent them yet, they would be swept back in with the general revenue. And in that case, I think what our concern would be is that providers would be much less willing to give.
But so you're saying with the special revenue account, that actually doesn't happen. I mean, it's not swept, it stays in the special revenue account.
Chairman Wilson, yeah, thank you very much. So we have these type of accounts for the various facilities, like the Wyoming Retirement Center. So the revenue it collects is used for that facility, or the public health lab charges fees and it has an account like this so that the fees it collects are used for the lab. And generally in that case, I believe it's used for equipment and other things for the lab. So to make sure there's actually a revenue source for keeping the lab up to date. So in this case, we would be using it in a similar way just for operations, but also any enhancements that needed to be done.
Okay. And Representative Ottman, I think you had another question, and I probably forgot what it was, and Mr. Springer might have forgotten what it was too.
Yes, thank you, Madam Chairman. I was wondering is how the different entities, because we talked about 4 different states, are you actively soliciting or recruiting doctors' offices and medical centers and things like that? Thank you.
Jesse.
Chairman Wilson, Representative Ottman, we are actively recruiting, so we believe we'll add 500 to 1,000 more providers this calendar year during 2021. So we're at 1,500 right now. When we get Wyoming Medical Center to join, we think there'll be 500 possibly by themselves providers. And then we have a number of ongoing recruitments and there's additional hospitals that are actually and large clinics, physicians' offices that are in various stages of onboarding. So, when I give that list of hospitals, we are trying to get every hospital to join. In some cases, some hospitals actually already joined other states that we're doing data exchanges with. And so in those cases, we've just built the connection with that state. So we're working with Colorado. We already have that connection built with, it's called Carrillo. And so it's the Front Range Health Information Exchange. There's actually multiple health information exchanges in Colorado. However that developed, they have multiple. And then we have a connection with Utah, and that system is called UHIN, UHIN, and that's a statewide system, and that's currently live. And then we also have a connection with South Dakota, and we're working on enhancing that connection so it can do a full set of messages. Right now it can do what's called admit, discharge, transfer. So when someone admits, discharges, or transfers from a hospital, it gives notifications. And then what we're working on with South Dakota is to make sure that a full medical record can be exchanged. And then this year we're working with Montana. Montana just created a health information exchange, and they're ramping up right now. And we've started communications with them to connect, but they're brand new. And then we're also working with Idaho. And we've also reached out to Nebraska because we have a lot of care that happens in that area. At this time, Nebraska wasn't interested in joining, but I think after we have built out our system more, they'll be more interested in exchanging data with us.
Okay, let's go through some more questions here because we've got some people that want to testify too. Representative Flitner, I think you were next.
Thank you, Madam Chairman. I have several questions, if I may, just to follow up on Representative Ottman in terms of costs on page 3, lines 1 through 5, when it speaks of the fees collected and expended only for administration and maintenance costs. Mr. Springer, if you could maybe give us an idea of what the Department of Health anticipates their annual costs for this program to be. Second question, you speak of intrastate involvement. What about interstate involvement in terms of our smaller rural hospitals or frontier hospitals within the state? How many of those are participating? And then if you have time at the end, if you could just maybe elaborate again on the roots of this program. I know it began with federal dollars. It began in a budget footnote. The Department of Health probably did not request this, nor did the state, but here we are. So only if you have time for that third question. Thank you, Madam Chairman.
Mr. Springer.
Chairman Wilson, Representative Flitner. So the third question is actually the easiest. So this came with 90% federal matching funds as part of an array of technology initiatives the federal government's been doing over the last 10 years. And so the state needed to come up with the 10% matching funds. And this system was built and run for the last few years with a budget appropriation of approximately $1 million general funds and $9 million federal funds. And so we are seeking to continue running the system to the extent we can with federal funds. And we do have some opportunity to do that over the long term. And to supplement that, because some of the federal funds will start winding down over time, these fees will be essential to running the system as those federal funds start winding down. So internal operation, internal recruitment, we have recruited basically all the hospitals. So we're working on critical access. And so the array, we're not taking big hospitals first or small hospitals first. We're taking any willing provider that wants to join and is ready. A number of providers have not joined just because they weren't ready, or they were in the middle of an electronic health record project. And so they wanted to finish their project before they joined. And so a few finished their project, and then a few months later, we were able to circle back with them, and they were willing to join. Some were just too busy with other initiatives, and they say check back with us in a year. And so we've been actively recruiting. We actually have, as part of that federal funding, the contract that we have, a big portion of that is actually a dedicated team to reaching out and recruiting Wyoming providers to participate in this initiative. And so when we say we have 1,500 providers, what that looks like is I think about 400 or 500 organizations. But as we add more organizations, some organizations have 1 or 2 users. And so a lot of those we've been enrolled to be viewers. So they're viewing information, but at this time, they're not actually contributing to the exchange. And then we're working with large clinics, Indian Health Service, the hospitals to actually become data contributors. And as we go along, we're trying to move more of the participants who are only viewing into data contributing, because it just helps. It helps for the full picture. We're also supplementing the system with pharmacy data from the Medicaid paid claims, so that there's more of pharmacy fill out, and then we'll be pursuing that as well. Chairman Wilson, did I miss a part of the question? I'm sorry.
I don't think, although I'll ask Representative Flitner, but just to circle back. So looking at the fiscal note, it says the estimated total operating cost in fiscal year 23 is $500,000, and that you estimate 20% may be covered by Medicaid, and the remaining $400,000 you estimate 50% funded through the voluntary participant fees. So are you thinking for the other 50% of that to be very stringent on your expenses, or are you thinking that there will, I mean, because I know that this will have to be re-referred to appropriations, they will bound to be asking, is the remaining 200,000 probably general fund or what?
Chairman Wilson, I think it's a bigger package. So we have a number of technology systems, and what we're actually doing is ending contracts for 2 or 3 other systems that the department had been operating, and we're moving that funding to support this system. So it's a little bit challenging in the fiscal note format to show something as complex as that. But the department's already spending money on related activities. And so the thought is to stop doing those activities and to actually basically put all of our effort into this system. So there's a Chairman Wilson and Representative Flitner, there's a good example is we were operating at a Medicaid health information exchange that was exchanging records just for Medicaid clients. And we are in the process of phasing that system out. So that contract ends, I think, August 31st, 2021. That system will produce savings when we end that system that can be used to operate this system. And so that's what we're actually working towards. But also is seeking additional federal grants. There's a number of things. And so we're not thinking that there's going to be an additional appropriation. And that was a question from the Legislative Service Office that did we need an additional appropriation, but we don't believe what we do. We are, I think, Chairman Wilson, trying to run this more efficiently, I think is what the.
Okay. Representative Flitner, did we miss any of the questions that you asked? You're good? Okay. Representative Clifford.
Thank you, Madam Chairman. I have a question about the when a patient will opt out. If things change, how does the process for opting back in? Can they opt back in?
Jesse.
Chairman Wilson, Representative Clifford, the process of opting in is very similar to the process of opting out, but there's a form. So if you've opted out, you are opted out. And so to opt in, you have to actually make a choice and take an action, which is to opt back in. And so there's a form you submit, and then we would process that, and you would be opted in. So there, we need that actual authorization because you've given us a legal authorization to opt you out, and so we actually need to do the reverse, a legal authorization opt you back in.
Okay.
But again, that we can complete those very quickly. As needed, even if someone needed that done very quickly, we could get that done.
Okay. Representative Hallinan.
Thank you, Madam Chairman. I'm sorry I couldn't opt in on my internet, but I'm here now. I
Glad
have
to
a
see you.
question, and perhaps this has already been answered. Is this information going to be available to the federal government? These items, are they going to be provided to the FBI and the other governmental organizations? Thank you, Madam Chairman.
Mr. Springer?
Chairman Wilson, Representative Hallinan. So we're not currently doing any exchanges with the federal government, and the purpose of this is for medical treatment. So I don't believe that any data would be shared with any entity like the FBI in any timeline. If someone had a court order, they would likely get that court order sent to their provider, and then the provider would we would not be subject to any court orders. So the court order would actually go to the provider, and then the provider could determine whether they would actually share the data. But we as the Health Information Exchange are not going to share any data with any law enforcement agency. From a federal entity standpoint, we are working to try to exchange data with the Veterans Affairs because we have a large veterans hospital. We have actually numerous veterans entities in Wyoming. And so we would like to actually exchange medical records with the Veterans Administration. So for the Veterans Hospital and the Veterans Nursing Home, we would like to be able to so they go out and get treatment. You can actually receive treatment outside the system, the veteran system. You come back into the system. We are working on that. It's actually quite hard to establish connections with the Veterans Agency, but it is on the list of things we're doing. But Chairman Wilson, Representative Howell, I think you're kind of implying we're like feeding some massive government database or something, and that's not the intent. And the data would only be shared on a single call. So, if there was a veteran, we're not going to share all the data with that. It would have to be to say, I am actually treating Jesse Springer, and I know these facts about him, including birth date, Social Security, other identifiers, and then you could pull the record. But you're not able to just pull mass records on all people. You have to be an enrolled provider or enrolled participant in this, and also know enough identifying characteristics about the person to make a request.
Okay, Representative Romero Martinez.
Thank you, Madam Chair. My question for Jesse is, they've been talking about this for a long time. My first question is, have there been chambers of commerce and health consortiums within the region in this conversation? That one's an easy one because it's just a yes or no. And then, because I think I've heard some of those. And I'll just start with that question. I think I have another one.
Chairman Wilson, Representative Romero Martinez, this I think was originally requested by the Hospital Association. I'm not sure about the history of how it actually came to be, but on our executive committee currently, we have the Wyoming Medical Society, the Primary Care Association, which represents a lot of large clinics that are publicly run, the Hospital Association, and a large number of providers. So I think those would be the kind of consortiums that you were mentioning, but those are the main targets of this, I guess. But we're also working with a number of other public health entities and other things to try to find where there might be value of this type of system.
And I remember the other question.
Mm-hmm.
The other one was in relation to your efforts and interest in reaching out to the Veterans Administration. Going back at least, probably 21 years, the Department of Defense has been issuing what they call a CAC card, a CAC card. It stands for Command and Control, and it's their new ID. There's a microchip on it, not to sound spooky, but the intent was from the very beginning. It's basically like your debit card, but the idea was to be able to house health information on there. I was on the implementation team for that for the United States Air Force base here in town and the 2 Guard units, and I know they still use them. They said we're not going to get to the health piece for about a decade. I just wanted to put an input that that's where you would go that I know of. I don't know who the officer is for that, but do you have any feedback or knowledge on that area relation to trying to work with veteran, not just veteran hospitals, but even military members?
Chairman Wilson, Representative Romero Martinez. So the federal government's built something called Sequoia. And so Sequoia is a health information exchange, I believe, for the internal use of the federal government, for the federal government treatment entities. Just because the federal government runs a number of health programs and treatment for veterans. And so what I understand is the electronic health record system they're using for the Veterans Administration has been connected to Sequoia. And so when we're trying to work through this, and we're still working on agreements, Sequoia is what we would connect to, and then they would connect us to specific limited pieces of Sequoia. So Sequoia is like, I believe, like a data interchange. And I believe it's working like a health information exchange. The most of the federal government's using Cerner as an electronic health record. And so we would basically be connecting some sort of interchange at Cerner.
Okay. I
Thank you.
see Representative Hallinan's hand is still up, but I think maybe he just didn't put it down. We do have a couple of other people in the waiting room. Oh, here's Representative Hallinan. Did you have another question? Your hand is still up. Okay. All right, then let's just, so that we can make sure to get everybody in, let's keep Mr. Springer on reserve. And Carla, could you let in Mr. Boley?
Yes, Ms. Chairman. Here he comes.
Get it. Good morning, Mr. Boley. If you could introduce yourself for the benefit of our new members. Those of us who have been around a while kind of forget how new some of the folks are. Not you, but I mean, anyway, go ahead.
Good morning, Madam Chairman. Eric Boley, I'm president of the Wyoming Hospital Association. I also serve on the executive council for the Health Information Exchange, as well as some of the subcommittees. We have 4 subcommittees that range from marketing, public outreach. We also have the financial stability subcommittee. And so I've been actively engaged as we built this health information exchange, and as we actually attempted to build one many years ago. I'm just here in support of this particular piece of legislation, and I'm happy to provide answers from a hospital perspective if necessary, but we feel this legislation is important. Our hospitals, the other providers, will be paying subscription fees or whatever you want to call it to continue to sustain this into the future. And we feel this legislation is important because it will protect those monies and will keep them where they need to be, which is supporting the health information exchange going forward after the federal funding runs out. I would tell you that this is really important for a lot of different reasons. It's important for consumers. It's important for providers, physicians, PAs, nurse practitioners, and it's important for hospitals. There are a lot of great benefits to the health information exchange, being able to share that information readily amongst other, from one provider to another. From a consumer standpoint, it would allow for tests to be run at one facility and then shared in another. Could help with reductions in duplicative testing. It could also help with continuity of care. And I think the thing to realize is that we've done a lot over the years. The federal government mandated that electronic health records be implemented in all of our hospitals and all of our clinics across the country. They actually incentivized us to do that, but they also held a really heavy and big stick over our heads if we didn't do it. So we've created these electronic health records where we now have very good records that can be shared. This health information exchange just gives us a vehicle to be able to share that information with permission from the patient amongst providers. I could answer a whole lot of questions. I know this committee is new, and there are a lot of acronyms and different things that you're going to hear. And I think we have a lot of education that we're going to have to do just to help you make sure we are explaining things properly. But with that, I stand in support of the legislation and would answer any questions.
Representative Flitner.
Thank you, Madam Chairman. And Eric, why did the federal government mandate electronic health records?
Eric.
Madam Chairman, Representative Flitner, I think it's a great question. I think realistically, it was an attempt to help with continuity of care and to help drive down the cost of healthcare across the country. You know, when you have a paper chart, it's pretty fragmented. When you have folks that are doing things that they probably shouldn't be doing, as far as seeking drugs in one state or another, there are many different things, but I think that the reason that they did it is to try to improve continuity of care and create the ability for providers to have better records and then to be able to share those. So without the health information exchange, we have been able to do that. We've been able to put records on thumb drives or discs back in the day and share those, but there were always some issues with how easily those could be accessed and the quality of the images and things that were captured. With the health information exchange, that's become much better, and it'll allow the images and things to be shared in a better format so that providers from one facility can look at them at another. And I'd use a CT as a great example, a CAT scan or an MRI where you're doing imaging that needs the highest resolution.
And Representative Flitner, I'll just put in here from my own perspective as a former healthcare administrator and now with my translation business. Certainly the mandate for electronic health records, I think, has been a pain in the butt for a lot of providers, okay, just to be really honest. A big pain in the butt and an expense. Whether we do this bill or not, that mandate will not go away, you know. But I will say there are some benefits which, you know, sometimes I'm unwilling to admit because it is kind of annoying to have your provider sitting there typing into a little thing while you're trying to talk to them. But in my translation work, a couple years ago, I did for several years a lot of translation of medical records from Puerto Rico for people who are applying for disability claims. And most of the records, because these were on appeals, were older ones, like 10 years old, and they were all handwritten. And I have to say, the challenges that I had in typing up medical records for a person who was trying to claim a disability, and considering how incredibly illegible most of the doctor's handwriting was, and I worked in healthcare for a long while too as a unit clerk, the ability, it was such a blessing when I would come upon a more modern record and it was all typed up from the computer. I'm like, oh, I can actually see what's wrong with this patient, rather than patient has illegible 16 blob, and you're like, oh, Lord have mercy. So I just want to throw that in there. We've all had our twitch on the health records. And I just want to say, and the other thing is that there are a lot of different companies providing the software. And so from my perspective, and Mr. Bowley, maybe you can correct me if I'm wrong, but one of the challenges has been, you know, if your doctor uses X software and the hospital uses Y software, they wouldn't. So I think that this is an attempt to overcome that, the varieties of software products too. Is that, am I correct on that, Mr. Bowley?
Madam Chair, that's a good description. Each electronic health record has a different platform, and so this creates the interface to allow the information to be easily exchanged.
Okay. Representative Hallinan.
Thank you, Madam Chairman. My idea about the electronic health record is not quite as good as yours. My opinion is that it's used mainly to keep track of how much time that a doctor spends with the patient in order for the government to decide how much to pay them for that service. I think it's probably the main reason for the medical or for the electronic health records. We always had all of ours typed, so there was no difficulty in having the record sent to somebody else to look at.
Well,
And they had- and the
Dr.
patient-
Helen, and you are obviously a very thoughtful provider, unlike some.
And the patient had to sign a release for those records to be sent to another doctor or another practitioner. So that was a guarantee that there was privacy. And I think that the idea that lab tests and the x-rays, et cetera, I think that's appropriate that they would be included in this exchange. But I don't believe that the doctor's dictation should be shared, because that is personal information. And I don't believe that it's appropriate that this exchange would have all of that personal information made available to whoever is able to access it. So for that reason, I'm kind of concerned about this bill, because it does include the doctor's dictation. And that is a doctor is supposed to be able to say that nothing that he says is going to go outside of his office. And I think that's the appropriate way that a doctor-patient relationship is. So for that reason, I have some questions about this bill.
So,
Okay, well, thank you, Madam Chairman.
so Representative Helen, let me ask a question here, not as a clinician, but suppose your patient came in to see you on Thursday, with symptoms of bronchitis, maybe edging toward pneumonia, and you wrote up your assessment of, their heart sounds, their lung sounds, and all that sort of stuff. And then on Saturday, they go to the hospital. Don't you think that information, your evaluation of them on Thursday, would be helpful to the ER doc on Saturday?
Madam Chairman, I don't know the answer to that question. I think that's possible, that it might help them. And they could call me on the phone and ask me, what was my findings on Thursday? But if the patient is able to tell them that they were in my office and I thought they had an upper respiratory infection, and then they developed these symptoms of pneumonia, I think the doctor ought to be able to make his own conclusion on that. I don't think he'd really require that he'd see my estimate of Thursday. So with that in mind, I still think that the idea that a patient does not have confidentiality when they talk to their doctor, I still think that's a very significant issue. Thank you, Madam Chairman.
Madam Chairman.
Mr. Bowley.
Just in response to that, we definitely talk about billing, and that has nothing to do with this particular piece of legislation. We could talk about how physicians bill for their time, and that doesn't have anything to do with this. But it's another conversation we have. As far as access to the medical records actually belong to the patient, and the patient can request those at any time and get a copy of those and view their records. My understanding is that you don't have carte blanche with the health information exchange. There are certain pieces of information that can and cannot be shared. But I think what's germane to this is this bill has nothing to do with any of that. This bill is actually asking you guys to protect the subscription fees that come in from the end users. When we pay money towards the health information exchange, we're asking for those monies to be set aside and used to sustain and support the health information exchange. That's all we're really asking here. And that's really what the bill is about. I understand there's a lot of underpinnings and underlying things that we want to understand. And I think we should spend a lot of time on this, maybe in the interim, but what we're asking is just to make sure that when the hospitals and the providers and the insurance companies pay their subscription fees, that this money isn't siphoned off and put into general fund and used somewhere else. It's set aside to keep the health information exchange that we've spent all this time standing up viable and sustainable.
Very good. Okay, and I'll take further questions. I know we've got 2 more people at least in the waiting room, and really we want to be done with the entire committee meeting and the bill in a half an hour so that we'll be ready. We don't have to walk down the hall and up the stairs to the chamber like we often do, but I did see no more hands for Mr. Boley. I'm sure we'll want you to hang around, Mr. Boley, but Carla, oh, I'm sorry, Mr. Representative Romero Martinez. Sorry, I didn't see you.
Thank you, Madam Chair. I don't know that I have a question. I just have some comments and some personal.
Representative, let's just stick with the questions first, just so that we can make sure that if we've got comments, we can do it at the end when we discuss the bill. If that's
The question would be, and I'll do a hypothetical. A patient comes into a doctor, gets a diagnosis. It's a major diagnosis. It has to do with skeletal injury and traumatic brain injury. And now this individual owns his records or her records, requests the records. Then they get chicken scratch notes after ordering them, takes them to another doctor. They can't read them. They can't get the quality of care. Maybe not for weeks, maybe for years. This has been going on for a long time. So my question is, does this system help resolve those issues if they're in New Mexico and they're in a doctor's office that may be special, or even in North Carolina where they specialize in that specific form of ailment? Does this help give better information to the other provider in the other state?
So let me just confirm. So Representative Romero Martinez, you're asking how many states will our providers be able to access in addition to the surrounding states that we just talked about? I mean, could you?
Let me simplify it. How well does the information exchanged help increase the quality of service? I guess, thanks for letting me edit that long thing.
Mr. Boley?
Madam Chairman, Representative Martinez, I missed part of the conversation that was being put out in the waiting room, but for those that are able to exchange the information, this actually creates better continuity of care. And so for the states that we have the ability to exchange, and let's just use our referral patterns here in Cheyenne. A lot of referrals go south into the Denver area, in the southwest part of the state. A lot of that goes to Utah or over in Idaho, and north of us goes to Montana. So as we have those exchanges set up between the different health information exchanges, then those hospitals can more easily access these electronic health records with the images and all the things we talked about, help with better continuity of care, and hopefully to drive down some of the cost of that care to the consumer, because we may not have to redo some of the tests and other things that have already been performed in the referring facilities.
Okay, super. We're gonna, Representative Stivar. Okay, guys, keep track of the time here. Representative Stivar. You're muted.
Thank you, Madam Chairman. The question I have is misdiagnosis, and it's in the medical records. How hard is that to get out? I mean, if somebody says, okay, in Cheyenne, you've got cancer, and they start wanting to treat them for cancer, and they go get a second opinion, and it's not, but it's still in their medical records. It's been there 2 years, 3 years. How do you get that out with this health exchange? It's just going to follow them around, and it's going to depend on the physician, how much he reads of it, what happens. Correct?
Mr. Boley?
Madam Chairman, Representative Stivar, very good question. Again, it's not part of this bill, but I'll try to explain it to you. So your medical record's chronological. And so even if you have a paper medical record, those diagnoses are going to be contained within your paper medical record. If you go see another specialist and you get a second opinion or another diagnosis, that new diagnosis is going to be earlier on in the medical record that's received by attending physicians or whoever may take care of you. And so nothing's ever removed from your medical record, even if it's paper or electronic. It's going to have to do with the chronological order of treatment. And so if new diagnoses or new treatment is started, that would be contained within your medical record.
Representative Hallinan?
Thank you, Madam Chairman. Mr. Bowling, you said that some parts of the medical record not be shared. Which parts would not be shared?
Mr. Bowley.
Madam Chairman, Representative Helen, it's a good question. I think Jesse, Mr. Springer did a good job of that, but a lot of the mental health issues within your medical record, I don't believe would be shared. There are other components. I think Jesse'd be a little bit better at explaining those that are contained or not contained, but there are certain parts of your medical record that are not part of what's shared electronically.
And Mr. Bowley, I just say, so it sounds like from what Mr. Springer said, that the provider could certainly limit what they put in. I mean, if we understand correctly that from, for example, South Dakota, all we're getting is that the patient was admitted or discharged or transferred, obviously that's all they're putting in. So I would suppose that if for some reason the provider said, I have a moral refusal to share EKG results, they could fail to do that, I guess. Is that right, Mr. Bowley?
Madam Chairman, I don't know the answer for sure. I think Jesse'd be better at answering that. I'm sorry.
Committee, let's go. We've got two more to and Dr. Jackson, I think Carla is next up.
Yes, let me bring that gentleman in.
All right. Good morning, Madam Chairman. I will keep this very brief.
Just introduce yourself for the knowledge of we've got a lot of new folks on the committee, if you would please.
Okay, I'm Dr. Ryan Jackson. I represent the Wyoming Business Coalition on Health, and this session I'm also representing the American Cancer Society. I'm just calling in to speak on behalf of this bill. I understand that this is not changing any of the federal laws, and this is more about maintaining this database that they're trying to get funding for. And so I think that this improves quality of care and patient safety. So my organizations support this.
Great. Questions for Dr. Jackson? Okay, well, you might want to hang around. We may come up with something. We often are that way, but we'll let you go for the moment. Carla, I think we've got one last, Ms. Blair, if you want to let her in briefly.
Thank you, Ms. Chairman. I will let her in. And you also have Jesse Springer had his hand up.
Oh,
and
let's get that answer first. Jesse, did you have a follow-up?
Chairman Wilson, this was to Representative Hallinan and Representative Stivar's questions. So there's a structured set of information that's shared. It's called the continuity of care document format. So it's only sharing certain fields. So I think we went through this, but discharge summaries, allergies, consultation notes, diagnoses, possibly summaries of procedures provided. And it really depends on what the provider has set up to share with us. And so if there's a notes field that they consider confidential and there's a notes field that is for sharing in their system and they choose to share the one that's for sharing. But the provider really directs what's shared with this system. So in their setup, they could say, we don't want to share this notes field. That's our confidential notes field if that's how they chose to set it up. But there's a structured set of fields and things that are outside that structured document, which basically is what you need for like allergies and blood type and those type of things. Services provider diagnosis is, if it's outside that, that structure, then it's not shared. So I think long text descriptions are not commonly shared. So we generally have short text summaries that are shared. So I think that I don't know if that answers the questions, but it is directed by the provider. So when we're onboarding them, they choose what they're going to share with us. But it's all limited within the structure of this format. So, you know, you can't share anything that's not inside the continuity of care document format. And that's a standard document that's produced outside of from the electronic health record.
Good. I think that's good information, Mr. Springer. Okay. All right. Folks, we have one more. Ms. Blair. So, Ms. Blair, welcome. And I've got 5 minutes for you because we've got to go into session at 10 and we got to work the bill. And I do want to point out the email. We did receive the email from you. We are considering Senate File 54. You had some numbering there about 56, which is not, and so we're not discussing anything to do with opioids. This is
I got it confused. I'm sorry.
This is specific, and so anything specific to Senate File 54 on the health information exchange. Thank you.
And I got that number wrong, and I apologize for that.
Okay, what would you like to tell us, Ms.
Okay, first of all, my name is Margaret Renee Blair, and I am a pharmacist with the state of Wyoming. I am active, although I am disabled, so I am not practicing at this time. And I noticed, I'll let you read my email. I'm not going to go into that. It's too long. I do have one thing to state. Doctors and pharmacists are the people that your patients are going to trust. So if you're recruiting and you would like your patients to be assured of this program, of this electronic health record, that's who you need to really target to get the message out to your patients. And it basically goes doctors, patients, government. Okay. So if the doctors are assured of it, your patients will be assured of it. Pharmacists are assured of it, your patients will be assured of it, and then they will be on board. Pharmacists need this. I'm going to be blunt with you. We do medical therapy management for Medicare, and we have no access but prescriptions, and we need something like this in order to do those more accurately. All we have for care is what the patients tell us and what medications they're on that we have access to. So we need this out there in order to see anything. As far as an answer to Representative Romero Martinez, as far as patient can, as far as quality, increase in quality of service, yes. You might not have your, like say that patient may not, the appointment out in North Carolina, they might not be on the system. But if their records are on this type of a system, and all you have is the chicken scratch before, that patient can come in, request the records off the system, print them off. They are legible then. So then they can take that record to the appointment in North Carolina and they can read it. Whereas before, all you had was the chicken scratch from before. And believe me, even a pharmacist has chicken scratch. So you could go to your pharmacist and they can write something out, but you may not be able to read it. Okay, so with a electronic healthcare record or electronic health record, you print something, the records you get are legible. They are printed from a printer. They're not from the previous paper record of chicken scratch. So even if your doctor in North Carolina isn't connected, you still have records that are legible. And it facilitates a better appointment. As far as EHR that was launched on federally mandated, it was continuity of care. It was a decrease of medical errors. All of that was to answer that question. The medical errors were out of this world. They still are, but that was the hope for the federal government, was to decrease the medical errors that were causing that, all the paper records were causing. I don't know I just see that if you're going to opt, people have that option of opting out. The more you have that option, the more they're going to opt out. So you really need to appeal to the doctors, get them on board as much as possible. That will translate to the patients if they're secure and the doctors are saying, hey, this is the best thing, this really helps us. The patients are going to jump on board. They're not going to trust anything from the government. They are going to trust if their doctors are on board. They're going to trust if their patients, their pharmacists are on board. But you guys, you're doing this. So it's up to you to show that it's worth it. So
Ms. Blair, thanks for, you've got really great comments, and I want to make sure to let people have time to ask you a couple of questions before we work the bill. So does anyone have any questions for Ms. Blair? Good background, I think, for us to hear from a provider perspective.
And I worked in the VA and the Indian Health Service, and I've seen it mandated, and it doesn't work that way. So,
all right, that's super.
Everybody's going to fight you.
Thank you, Ms. Blair. I thank you for your email too, folks. You can look at that. I hate to cut you off, but we want to make sure to have time to work the bill just in case there are discussions that come up. Thank you so much. Okay, Carla, is there anybody else in the waiting room?
Madam Chairman, yes, there is. Fran Fuchs from Department of Health and Joe Slack.
Very good. Send them in. Franz, are you there?
Good afternoon or good morning, Madam Chairman, members of the committee. My name is Franz Fuchs, Policy Analyst, Department of Health. I was just here basically just for any general questions from the department, but I'm sure Jesse is far more qualified to answer specific questions to this HIE. So
thank you for coming, and I apologize for kind of failing to organize all my timing early on. Folks, I think we've asked pretty well. I would, if there's anything burning in your mind that you think Mr. Fuchs can answer better than Mr. Springer, but Mr. Springer is obviously the detail man here. Okay, and then Carla, Mr. Slack, I think you said?
That is correct. I'm bringing him up.
Don't know who that is. I'm sure he will introduce himself. Mr. Slack, if you'll introduce yourself, please. Mr. Slack, if you're talking, your mute is still on and I can't see your picture. Kyla, do we seem to be having trouble with Mr. Slack?
Madam Chairman, I've asked him to unmute and to turn on the video electronically.
Okay. Mr. Slack, if you can, we don't have a lot of time. I'm going to have to close public comment if you can't get in. You could send us some email though, if you like.
Madam Chairman, I'm not getting a response.
Okay, then committee, I'm sorry, Mr. Slack, we can't hear you, we can't see you. Please send us an email if you've got something you want to share on Senate File 54. Okay, public comment is closed. Committee, do I hear a motion on the bill? Moved by Representative Connolly, seconded by Representative Ottman. Okay, is there any discussion on the bill?
Question.
Well, question being called. That was speedy. Some people must have some coffee to offload. Carla, would you call the roll, please?
Thank you, Madam Chairman. On House or Senate File 54, Representative Clifford.
Clifford, aye.
Representative Conley.
Connolly, aye.
Representative Flitner.
Representative Flitner, aye.
Representative Hallinan.
Representative Hallinan, aye.
Representative Ottman,
Representative Ottman, aye.
Representative Romero Martinez,
Representative Romero Martinez, aye.
Representative Stivar,
Representative Stiver, no.
Representative Worf,
Representative Worf votes aye.
Chairman Wilson.
Chairman Wilson, aye.
8 ayes, 1 no.
Okay, committee, it looks like we will have to re-refer it to appropriations, just because it's got the special revenue account on the back. Looking ahead, if there are any of you, and I think used to be the chairman would just no Representative Stivar. I think this is your trick to just get out of presenting bills. Anyone who feels a great interest in this bill, please just communicate on the side with me, because it will take a day or so to get it through appropriations, and I'll be glad to help anybody with information from the PowerPoint and that sort of thing. If there's someone who would like to present it on the floor. And with that, Carla, is there any other topic of discussion before we adjourn for the day?
Thank you, Madam Chairman. I do not see any.
Okay, so committee, that was sort of a sense of how much time we have with our new morning schedule. Those of you that have been around know that we often went on for hours and hours in the night. We won't be able to do that, which is good, but it also really obliges us to kind of be prepared. I know when I was on Revenue Committee for a while, sometimes then Chairman Madden would have us start at like 7:30, or I think sometimes even at 7, which frankly I think is horrible. So I really hope to not do that. But in order, you can see that, and especially as we get on into the session, I mean, we don't even have individual bills out yet. There's a bunch of bills, even the committee bills and some things that will need to work. So just, getting a sense of our timing, we'll need to either probably start earlier or, just really whip through things as far as testimony and discussion. Or a lot of bills will just sit in my drawer and not get on the schedule for lack of time. I mean, that's just a realistic thing. So just as we go forward this week, I don't have anything else that's been actually read in and assigned to us yet, but I do think that we will probably hear Senate File 53 on Wednesday morning. That's the ground ambulance bill, which was also an interim bill. We also have, hopefully, coming over from the Senate, another committee bill, Senate File 52, on mental health insurance parity. If possible, if we get it over, I'd like to do that Friday. And I think that one should be short enough. I'm hoping that if we start a little early, we might also be able to work that community mental health prioritization that we worked on a little bit. You remember back a couple of weeks ago when we had our 3 days, and that will then be the end. And then whatever comes out of that will just roll into when we start March 1st. We'll just remember March 1st, 8 o'clock in the morning. I don't think the first day of session I'll start at 7, but just so, and feel free to email me with questions about those, but hopefully we can get through them somewhat this week to leave space for, I know there are certainly individual bills, other bills that'll be coming forward, and we do need to have, because once the hopefully in-person session, I just feel like we'll be able to do really focused work. You've only really got a couple of weeks worth for whatever comes in the House, because then you've got the crossover. So it's not like we've got the whole month of March and the beginning of April to work on everything. Whatever starts on our end, we'll have maybe like 6, I think maybe 7 meetings to deal with them all, and that's all we got. So just kind of intro discussion on how that works for those of you that are new. And you've got 20 minutes from adjournment, run down the hall, get your second part of your breakfast, or 11s if you're a hobbit and you need 11s or something like that. And I'll see you all in the giant square of 60 at 10 o'clock. All right.